The doctor is in.
Hi.
Doctor is in. Hey, Dr. Kim.
Hi, how are you?
I'm so good. I'm so good. Dr. Mo's going to come on in a minute. She was hung up in surgery, saving lives, doing
Well,
her
she cannot interrupt that.
no.
Finish that, because that's
Finish that.
important.
Cut the boobs up. Do what you got to do. Cut the lumps out. That's her main job. We need her to do that every day. And so we'll hang on until she gets. But today we're going to talk about this topic that just disheartens me every day, and it's pain. You know,
Okay.
so many breasties are living with pain, and
Mm.
it's so funny because I tried to get a breastie on to talk about pain today, and nobody wants to talk about it. Who wants to talk about it, right?
Yeah,
So just
yeah.
gonna and you are dealing with this every day. So let's start by you've been on before. Thank you so much for coming back. Thank
Mhm.
you so much for joining our medical advisory board because I need you so I can ask you questions and have you talk about something I don't understand. But tell
Sure.
us about you. So talk about you and what you do, and so we can just give our audience a good background because we love you already.
Oh, well, thank you. And it's a real honor to be here. I'm Dr. Kimberly Cursine, and by training, I'm a palliative care physician, and also certified in internal medicine and geriatrics. And what I currently do now is I'm the director of outpatient supportive care at Emory Healthcare here in Atlanta. And I'm under the Division of Palliative Medicine, led by one of the most amazing Black women in the world named Tammy Quest.
Very
One of the
cool.
most amazing. And what we do here in our clinic is that we help support patients who have very serious illnesses, no matter what that illness is. We help them manage the symptoms of that illness, and that can either be physical, like symptoms like pain, spiritual, or social. And we provide an extra layer of support no matter where they are in the journey. So we're often seeing people who are just starting, we're seeing people sometimes in the middle, and then we also take care of people who are at the end of that journey, and to make sure that they have the best quality of life possible.
Well, that's awesome. And you were telling me a few minutes ago that you don't really talk a lot about breast cancer. Why is that? Like, what's up with the breast cancer space? Because you don't do any other spaces.
I think there's been a shift in the breast cancer space. Like for many cancers, um, in order to do what we are asking you to do, which is Herculean, we have framed the language in terms of fighting. So, you're faced with this incredible diagnosis. It's overwhelmingly big. You're faced with these treatments, which are overwhelming and big. And the goal is to be able to tolerate them so you can survive, so you can live. Um, and that requires dedication and strength and all the things we pull from. And so I think that cancer, and in particular breast cancer, has taken the fight mantra, and that you always have to be strong. You
Right.
always have to be
Fight like
grateful.
a girl. Fight like a girl.
Yeah, you have to be grateful. Everything is an opportunity, and this almost positivity, almost this sort of toxic positivity. Hi, hi.
Hey,
I'm glad
I
you're here.
made it.
You made it. You made it. Dr.
Yeah.
Kim was just talking about how the breast cancer space isn't always accepting of palliative care because of the whole like fight mantra.
Yeah,
Yeah, keep
Very,
going.
very true. Yeah.
and that fight mantra can be really useful to try to get through some of those hard days. The only problem with the fight mantra is that it doesn't leave. When you're a warrior, when do warriors get to be vulnerable? When does the warrior get to be tired? When does the warrior get to be done? Right? Or at least being able to have a place to kind of explore that. So when the palliative care kind of came along, and with palliative care being so hooked or so closely coupled with hospice for a variety of reasons, because we're both providing comfort just depending on where you are in your illness, I think it was difficult to sort of, how do you reconcile being the fighter and being the warrior along with requiring this extra sort of layer of support and vulnerability, you know how do I sort of manage that? And I think maybe oncology providers were concerned that how am I going to get her to do this, which is Herculean and super hard, because these, and if I introduce the idea that there could be a different way, or an idea that maybe you don't, would they not be willing to sort of walk through the fire to get to the other side? Would people give up prematurely?
Hmm.
So I think that, but as time has gone on and people started to learn what we do, and palliative care has adjusted their language to meet people where they are, I think we're starting to sort of see that, your ability to want to survive, to persevere, to look for the clinical trial of that strength is not diminished by the seeking of comfort, but actually being able to have that extra layer of support can possibly provide you with strength to be able to achieve what you're needing to achieve. And that even being able to explore and allowing yourself to conceive of, you know what, I'm going to do this and I got this. But you know what? I got a limit where I'm not, when I think that I may want to look at this a different way. And it's okay for me to explore that. I can still explore my thoughts and concerns and what I want my life to look like, and what I even want the end of my life to look like, at the same time as saying, yes, I'm going to MD Anderson for that trial and I'm going to do it. Like, you can hold both spaces. And I think that's a maturity in the oncology breast cancer world. And that's a maturity in the palliative care world, where we're both no longer looking at it in this binary way, but also seeing how it's important that we work and fit together. That there's strength and vulnerability.
It's such a nuanced conversation. One of the things that I heard you say when I just tuned in was about oncologists not necessarily offering certain things out of fear that patients would not then opt to treat potentially treatable disease, or that they wouldn't fight. And it's paternalistic. I think that we have to educate ourselves as doctors to be able to offer patients every option and help them explain how these things work together. And it's so it's nuanced in the sense that if we can open our minds to the fact that palliative care is an important part, an early part, an adjunct part to the care that we provide, how much more now should we open our hearts and our minds and our education, right? And get engaged and learn about things like complementary medicine, right? So when we talk about pain, bringing this conversation full circle, pain can be treated in a lot of ways that we know, but there's a big black box of fear among physicians when it comes to treating pain. I see it in surgeons. They'll only give 10 tablets of this. They're not going to do that. They're going to tell patients, you shouldn't have this XYZ. You shouldn't be experiencing these things because it's out of the scope of their common practice or their common experience. And I think just as we look at the ways in which palliation can even augment treatment, right? It doesn't have to be a fight. Sometimes it can be a surrender. But we can also consider the facets of other ways to help our patients that are beyond the scope of the things that we learned about in medical school, because there's a whole lot of things going on in the cancer space. And one of the things I love about practicing in oncology is that it continues to grow and push the envelope and change. And the way we treated breast cancer, 5 years ago is totally different than how we treat it today. It's totally different than 10 years ago. It's totally different than 5 years from now. 5 years from now, I envision there's going to be all kinds of clinical trials looking at the ability of palliative care to augment clinical trial success and maintenance and enrollment and other things, and the ability of things like CBD to help patients with sleep and with pain and all these things. Like, we gotta open our minds to it, because patients want it.
Yeah, and and you can see that we're very much in that space now. One other thing I would say about the warrior or the fight metaphor, although I can see how it can be useful, the fight metaphor somehow implies that we will hear women lost their fight, that you failed.
Right, that you failed.
Like you failed, like we even say she failed breast cancer treatment. I'm like, did she fail treatment? I don't think she failed. I was like, you can't fail at this.
Can't fail treatment.
Yeah,
right.
so, that dichotomy that we kind of set up
Mm-hmm. Mm-hmm.
starts to turn
Sure.
when things change. And so what happens is, we're saying you fight, 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 and the patient's absorbing, yeah, I'm going to fight, fight, fight. And then as things aren't going the way we hoped, we start to change and we start to accept that, oh my goodness, maybe this isn't the right way to go. What we failed to do was tell the person. So they're still fight, fight, fight. And then all of a sudden, one day we come and say, well, we think that you should look at this differently. Maybe we should focus on comfort. This treatment's not helping. And the person's like, what are you talking about?
Right. Right.
This is my mantra. You told me if I was good and if I ate right, if I did the treatments on time, if I didn't drink the alcohol, if I had clean living, that I would be okay and you would be in my corner. And now all of a sudden, you are telling me I need to think about it a different way. And now you're even annoyed with me that I
Hmm.
don't get it.
Hmm.
Right. So
Boy. Oof.
so that's the problem. But if
Yeah.
we look at this as a journey and we say, this is going to require your strength and I'm going to need your vulnerability. And and everything that you have done up to this point has been a blessing because the treatment did exactly what it was supposed to do. It gave you time. Nothing can give
Hmm.
you forever time, but it gave you time.
Mm-hmm.
So this was a blessing. This is a journey. This is what it was supposed to do. And now we're going to look at this differently because I'm only ever here to help you. These are the things that will help you now. You didn't
Right.
fail. I've never met a patient who's ever failed anything.
Nope.
Most of them do everything we ask them to do, and 10 times more in different others, other non-traditional spaces. So nobody fails at this.
Mm-hmm.
It's nobody's fault, but the warrior fight mentality sets up that as a fault. And so it's hard to let go of that
Yeah.
and
Yeah.
hard not to feel like if I was strong enough, I can take the
Mm-hmm.
pain. You hear people say, I can take the pain. Yeah. And I think it has a lot also to do with, how we're socialized as women, and particularly Black women,
Mm-hmm.
to be strong,
Yeah.
bear the burden, um,
Check it out.
suck it up, not take,
That too, right.
yeah.
They should just be glad to be alive. I see so many patients, they're uncomfortable. And, being the younger member of a practice, inherit a lot of patients from
Mhm,
surgeons who, have retired and that sort of thing.
mhm.
And I follow their patients and they feel like they should be grateful to be alive and that this
Grateful.
is just the state of things.
Yeah.
And I guess this is just something I'm going to have to live with and don't complain.
Yeah.
Right. Isn't that something that we learn as Black people, right?
Mhm.
Don't complain, make the best of it. God will make a way, God will provide, and then just keep pushing forward, keep being strong. You hear that terminology, and I
Right.
encourage my patients to actually surrender,
Yeah.
right? What if we surrender to this lesson? What if
Mhm.
we surrender and give into this pain and stop doing so much? And what if we break down and ask some questions? What if we surrender to some things? And what can
Mhm.
that look like in a sense, not of relinquishing your power, but
Mhm.
in, like you said, in owning, right, that vulnerability. And I think that is a reflection that more of us could look at. And it doesn't maybe sound so good on a t-shirt, right?
Mhm.
Because nobody wants to surrender to breast cancer. But what if you surrender to this life lesson
Mhm.
about peace being non-negotiable, about your diet, about your nutrition, about your existence here on earth, about your
Mhm.
purpose, about all these other things that, when people who have adopted that mentality look at breast cancer as the blessing, it's almost that sort of a taboo terminology where all of us, wait, what do you mean your breast cancer was a blessing?
Yeah.
And there's some things there.
Yeah.
Yeah. Can I talk about my friend Allison? Because
Sure.
we
I
have
love
so
Alice.
many things that were in what happened with her. So these are her boots. I
Mhm.
bought them for her warrior boots. She wore them every day for 2.5 years, even in the summertime. I'm like, Allison, but these are her warrior boots. So her mom gave them to me, when she died. But so she was one of my best friends before she had cancer. I've met so many women who were dying when I met them, but
Mhm.
she was my friend before she got cancer. And I didn't know her the first time she had cancer. She had cancer 10 years earlier, at age 36, when her son had just been born, ER positive. Did all this stuff. She had stage 3 ER positive, so it was pretty serious back then. She had BRCA. Um, fast forward 10 years,
Mhm.
we were going out to dinner we were going to have a party. It was our 10th cancer anniversary. So we actually got placed. One of my good friends is Kenny Leon. So we got placed to a Broadway show like the night before opening night. We're going to go to dinner at 21, and we were hanging out of a bunch with my TNBC board member friends, and we're going to hang out in New York. Girls' night out. And we go out to dinner. We have this great night. It was this riveting play called American Son. Have you seen it? It's on Netflix, right? Crazy. You have to watch it.
I saw it on Broadway. It was so good. Kerry
Yeah.
Washington.
Yeah,
Loved it.
Kerry Washington. Yes. So
Yep.
we got to, we hung out with what to be. Kerry, my good friend was the director, Kenny Lamb. So after the play, we're like, oh my God, that was so crazy. And we made him come talk to us. We sat at the top of the Marriott place where it spins around, whatever, till they close us out, like interrogating him about all this stuff. We had this great night. So now we're gonna leave. It's 1:00 in the morning. We got kicked out of the restaurant. And then we're walking to get an Uber. And so Allison says, I have this pimple on my neck. What do you think? What do you think it is? And so I said, I don't know. So we think I should get it checked out. It looks like a pimple, but yeah, you should probably get it checked out. Thought nothing of it. 1 week later, metastatic TNBC inner lymph nodes. So
My goodness.
So I think she was 46. Yeah, 46. Her son was 11. So now we're in this whirlwind of metastatic triple negative breast cancer. And it's funny because, I've been an advocate forever. She never wanted to talk about breast cancer. After her first bout, I said, come go to the party with me. Come go to LBC with me. I don't want to talk about breast cancer. Yeah, I'm done with breast cancer. So now we're in it. And so I'm like, Allison, we're about to go to LBC conference. I had all my breast cancer stuff lined up and I wanted to drag her with me. It took her a minute to get there, but I said, we got to go figure this out. Like, what are we going to do? What are we going to take? And we'd done a lot of work, obviously, with Trodelvy and with Tecentriq, and we knew all the drugs. And that night, we were with the board of the Triple Negative Breast Cancer Foundation. All the players were there. She had all the cards laid out, right? So we go to the whirlwind, and she did everything. She did 8 treatments, 8 count them in 2.5 years.
Mhm.
So 8 treatments. She did everything. She fought like a girl.
And for people watching, Ricky, you mean 8 different lines of therapy,
Yeah.
right? Because this is the thing, right? So there's a
Yeah.
treatment, but then when one treatment seems to not stop progression as well as, as it used to, or we notice that disease progresses, or patients have really bad side effects, then they switch to something else. Then we use something else. We may add something else.
Mhm.
And so to do 8 different types of therapy in how many years? 2 years?
2.5.
In
Wow.
2.5 years it's really remarkable.
It
It
is.
really is.
We signed up for trials. We ran all over the country. We called every doctor you could possibly call. And, I was just all in it with her. Like, I couldn't leave her alone. Like, I felt like she was my project, that I had to fix it. Like, this is what I do. Like, I have to save her. Right. And so it's so funny because we Zoomed pretty much every night. Like, her husband used to laugh. He said, freaking get out of our bed, because we're on FaceTime every night. And at 9:30, we'd be eating ice cream on Zoom, on FaceTime. They're like, Ricky, it's time for you to get out of our bed. But anyway, I just lived this with her. And so fast forward now, she's really ill. She's done. And so she called me one morning and she had relentless pain from the very beginning, relentless pain. The thing opened up, it oozed, it closed up, it came out of both sides. It was just a nasty, nasty, nasty cancer. But her pain was just ever present in her neck. It was like a weight on our shoulders. And so we would make jokes about, is your pain a 1 to a 10 today, Allison? Or which number is it? And we'd get that, we saw that smiley chart where the smiles from the front, ridiculous. And it was ridiculous. So how do you say it's a 10 or a 5 or a 6 or a smiley face? Like, what is that? What does it even mean? What's the reference point for that? And we would make jokes about it. Al, what's your number today? And my number is 248, because it was just stupid how they talked to her about pain. And she took a lot of stuff. She took morphine probably after a year in this process. It did nothing for her. And she tried everything. So now fast forward. So she called me one morning. It was 2 weeks before she died. She said, 5:00 in the morning. She said, Ricky, I'm dying. I was like, you're not dying, Allison. You're not. We're going to get the trial. We're going to do, like, I had my warrior boots on still. You're not dying. Don't talk about that. We're going to find another doctor. We're going to find another treatment. I said, no, Ricky, shut up. I'm done. I'm tired. It hurts. I can't take it anymore. But how do you get to that point? I remember the struggle it took for her to get to the point to say, I can't stand the pain. anymore. I can't stand the pain anymore. And so I didn't want to give in though to it, but I knew like she hung up on me. And then she called me back, have like, you have to listen to me. Like, I can't take it anymore. So help me tell my mom that. I'm like, And so she goes to talk to her mom and her husband. And what do? They take her to the hospital, like do something for my child, which is exactly what I would do as a mother. Right. And so we're going to take her to this pain doctor and like do some kind of pain surgery. But she was so tired and her little body was just so beat up. And she had fought like a girl for so long. And it was hurting. I didn't want her to hurt anymore.
Yeah.
But just to make the decision to say, as you said earlier, Dr. Kim, when do you stop? How do you make that decision to stop now? She was thinking about her 13-year-old son and her niece who was about to be bat mitzvah in a couple of weeks, and she had made a necklace for her. And she was thinking about like, well, should I die now because it's her birthday soon? Like, when should I die? Like, how do you make the call to say, I can't do it. I'm ready to go. Like, it was really, really hard at age 48.
Mhm.
Right?
Yeah.
With a son, with a family, with a loving husband, with great parents, with all kinds of friends. And so, we talked every minute we whatever said. So she decided for hospice to come. And she said, okay, like, how do we talk? Like, can you call hospice and check it out and see what they do?
Yeah.
Call hospice, I call her mom, I give her all the information, like I was like the secretary, whatever, fine, whatever, I'll figure it out. But one of her last things she said to me was, I wish I had written a book about pain. I wish I had talked about it more. I wish I had asked for help earlier. Like, she didn't want to burden her husband or her son or her parents or even me about, like helping her manage the medicine,
Yeah.
And at the end, she was kind of not lucid a lot. So she would miss a dose and she'd wake up writhing in pain because she missed a dose because she fell asleep because she didn't tell me to give her the pill. So it's almost like, do you tell your husband, like, when do you say, I need for you to manage this medicine for me? And, she was a badass. She didn't want anyone to manage her medicine for her or take care of her. She took care of everybody else.
Yeah.
So how do you let go of that and say, can you give me the morphine when I'm sleeping? Can you wake me up? And so she was probably in worse pain because she was trying to do it all herself.
Yeah.
Right. And take care of herself. And so now fast forward, she's pretty much dying. And I went to visit her and she wasn't lucid. And I didn't know that she knew I was there. And, I was holding on, she grabbed me and said, I need a Ricky hug. Like, I was so happy that she recognized that I was there with her, but she was still in pain. And we called the hospice nurse, like, she needs more something else. Like, this stuff is not working. And it wasn't until, we like got the hospice, like, take her blood pressure, you're right. And they gave her the fentanyl things and whatever, and finally let her have peace. But she died 3 days later. But the pain that she went through was relentless. It was horrific. It was excruciating. It was, her last number was, there's no number for this pain.
Yeah.
So how do you deal with that? But you hit on all the topics when you talked about that sort of transition from I'm going to fight, I'm going to fight, I'm going to fight, I'm going to put on the stupid boots, I'm going to walk on the walk. She did the 3-day walk with me, and she could barely walk. I mean, she barely made it through the first day. We had to carry her home. Haley and I carried her home the last couple of miles because her feet just couldn't handle it. But she wanted to fight to the, I mean, she fought till 10 days before she died.
Yeah.
And it was so hard to like give into that, but the pain is what stopped her. So what can we do for people? Like, how do we manage that? And I think you hit on it. It's not only managing the pain, but managing the peace, getting the peace, managing the transition from, I'm not going to do this anymore and it's okay.
Yeah. Erica, what you described, I mean, that's an incredible story, and what you were able to do for your friend and what she was able to accomplish is amazing. And what we see so often is pain is very complex. You have this physical pain in your body that is caused by what the cancer is doing, or what the treatment is doing, or what the treatment has done. And that's one part that we are trying to deal with. And but there's an emotional component to pain.
Yeah.
And so,
Very much so.
you know, and when they're, and you have, in order to manage a person's pain, you have to tend to both. It's like this circle, it's like these interlocking cogs. So you have the physical pain keeps you up, it makes you upset and emotional, and now you have more pain, you can't
Right.
cope with it, and you're in this cycle. At the same time, because you're emotional, depression starts, frustration, anger, all of which we repress because that's what we're taught to do. And they just sort of feed off each other in this larger ball. So when a person gets diagnosed, and part of what we should do, and I think a part of the reason why to get, whether it's a palliative care specialist, an integrative oncologist, a pain management doctor, a counselor, social, the part of the reason why you have to have that interdisciplinary team to tend to you is because that's the team that treats your symptoms as a diagnosis, right? So when you walk into your oncologist office, their job is to treat your cancer, and they do that beautifully. But at the same time, you're not your cancer, you're you. And when a person is treating you, then if pain is your primary issue, they're going to give you permission to say, you know what? We want to take that 3-day walk, but we can't do it if you are in pain, if your feet hurt. So if we can address that, that's going to give you the quality of life, and that provides the strength for you to do the other things you're hoping to do. That comfort gives time. If you are miserable, it takes time. The more comfortable you are, it's helpful. So the ability for us to normalize it, to put it out on the open, that the pain you feel is, number one, normal. It's not going to be like everyone else's. It's not imaginary. It's not imaginary pain.
Right.
It's
Right.
not imaginary. And then also us being willing to sort of address, the medications and what society sort of thinks. I have patients who will be in terrible pain. I'll convince them to treat their pain as an entity. They go to the pharmacy and pick up their prescriptions, and it's either they're looked at with disdain
Right.
as a drug
Right.
seeker,
Right.
or my favorite is pity. There's nothing in between. They're either
Right.
like, oh, I threw a few extra pills in there for you, bless you. They're like, either I'm pitied or they won't give them to me. Like, it's our reaction. So not only are they having to manage the symptom, but they're also having to manage our reaction to the symptom. Our patients who want to look at things more holistically, and maybe they want to visit a naturopathic doctor, and they want to engage Reiki therapy. We, as us allopathic medicine doctors, we take issue with that.
Mhm.
Our ability, we struggle with actually treating the pain, but we don't give credence or validation or leave a space often wide enough to accept for a patient to look for other ways to manage it.
Yeah.
We leave these gaps in our knowledge about what are some of the other things beyond our traditional therapies to manage. The other thing, as we're building our big cancer centers, one of the beautiful things I see developing in oncology is these integrated cancer centers where they are now paying attention and bringing colleagues like interventional pain management or radiology. Like you said, Ricky, but just like they're being super awesome with therapies for breast cancer with the goal to turn it into a chronic disease if we can't get the holy grail of a cure. The same thing is happening in the world of pain and symptom management. There's research and cutting edge, and what would be really helpful is if our organizations that are advocating for our cancer patients to advocate that if you give us access to this $10,000 a pill drug,
Right.
then you need to give us access to the physical therapy, the
Mhm.
acupuncture, the massage. Don't put me through 50,000 changes doing prior authorizations to get the medications my doctor ordered.
Yeah.
Pay the complementary medical providers and the pain psychologists, and provide access and demand that be an equal footing with my treatment. in the beginning. And that's what we are lacking. And if we believe that if we walk into our cancer journey and our fear about pain, but we walk into our cancer journey and accept this could be a part of my journey, but we've got this part. And when you feel this part, as aggressive as I am about getting you that infusion chair, I'm going to be as aggressive about treating your pain. And that doesn't mean that I'm going to, put you on the Lido deck with opioids. You might need a little some. They're not bad. They're wonderful medications, but that's not the end all and be all. And if we are doing that and we are, no matter what we have access to, leveraging that, and talking about pain openly and it not being a shameful thing. The other thing I think when we think about pain can be useful, because what do? We get sick and then we say, what are the NyQuil commercial? Oh, you have the terrible flu and COVID, take some NyQuil and now you can play with your kids and write that report. No, when your body is hurting, if you got a pain in your leg and you can't walk, you need to go sit down somewhere.
Yep. Yep.
And so the idea that you're supposed to go through your illness and nothing around the way you interact with the world is supposed to change is ridiculous. The pain is sometimes telling you what the limit is, just like the fatigue is. It's a warning sign. It's saying, hey, you can do this, but you know what? I got a metastasis here. You can keep doing this, but I'm going to pop. And the pain is saying, stop, 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 and tend to me, and tend to me. So the pain is your warning alarm signal that something is not okay. We can manage what's not okay, but it's okay to rest. And you're not giving up. What you're doing is, instead of working against your illness, you are working with your illness. You are taking control. You recognize, I can do everything I want to do, but I have to do it differently. These are my limitations, and I'm going to take control of those limitations. So yes, Kimberly, I'm going to take this medication every 4 hours, or I'm going to take it every 12 hours, because this is the tool that's going to allow me to be the mom. This is if I want to get to soccer practice, I'm going to use my pain tool. If I want to, do these activities and I want to go out on Friday night, I'm going to rest my body so I can enjoy what I'm going to enjoy. And then the next day I'm going to take to my bed in pajama day. And it's my choice. It's not the disease's choice. It's my choice, because I am now working within the limitation. I'm working with my body instead of trying to force my body to do something that it's not capable of doing, or it's telling me not to do. Right. Body's smart. Body only wants to do what it's going to do to preserve itself. So I think part of managing pain is being in tune with your physical body, being aware of it. And once you are aware of it, then learning how to communicate that. And what we as providers need to be able to receive that. And if we can't manage that, be willing to get you to some place that can manage. So that's sort of a paradigm to kind of deal with physical pain. The emotional pain that we feel is in why you hugged her and she relaxed in your arms, and she exhaled. We often forget that when people are struggling, they struggle emotionally, they struggle spiritually. And you can have everybody around you and they want things, and people that you want to, the constant. But when you showed up as her friend, you were just for her. And she could relax and let go of some of that. And so
the guilt that she felt with her family, maybe.
Right.
Yeah.
She felt like she was leaving them, or like taken away from them. Yeah.
Yeah. And that's the total pain concept. That's the suffering. Like, you've seen that. I'm sure you've seen that, Dr. Gary, when you have two women and you have done the same procedure. One is like looking around you at her stories while you're trying to tell her what her plan is. She's like, yeah, can you come back later? The other one is screaming down the hallway, has grabbed your arm, is rocking back and forth. You're like, yep. I did the same thing. What you're doing another scan just to make sure nothing was left undone.
It's true.
the difference between those two women, one has pain as an entity in itself, and the pain medication is going to take care of it. The other person is suffering, and
Psychological, yeah.
suffering
Yep.
attacks your personhood. Suffering is what you feel when you walk into the room. You walk into the room and it's almost abhorrent. You almost want to
Yep.
leave
Mm.
because it's so bad. And that
And
kind
you
of,
can't cut it out. You cannot. It cannot be
Total-
surgically removed. It's true.
that's total pain. And
Yep.
when in total pain, you have to not just address what's happening physically, but you got to get down to what's happening emotionally and often
Mhm.
what is spiritually. So,
True.
and we often leave that part out. Like we'll throw every medication in the book when who
Mhm.
they actually needed to talk to was your spiritual health clinician. If you've
Mm.
gone up on the opiate 10 times and nothing's touching it, that's not what the problem is.
You
You
know, I think this conversation, one, really underscores the benefit of involving and incorporating palliative care teams early,
Mhm.
right? Like we're having this entire discussion about how the mind, the body, and the spirit are connected. And being an osteopath, it's part of our training. It's ingrained into the training that the mind, the body, and the spirit are connected. But what are the resources? What are the techniques and the tools that we can utilize to help patients reconnect to those things and to treat pain at all those levels is something that is rarely taught in any medical school that I'm aware of. And I'm on faculty at 2 of them, and we're not at that level of teaching yet. We have not learned these things yet. But the fact that there are teams that are involved to help not only patients, but to help clinicians begin to unpack some of this so that it does not appear as if we are coming from a position of failure. We have failed, our medicine has failed, our whatever, our patient, our bodies have failed, all these things. But that there are some strategies and a team willing to and capable of addressing all of these things is really quite remarkable, and something that I wish more of us not only knew about, but that more patients would ask for early, because then
Yeah.
the request and the demand then drives the health systems to consider and to build programs such as this. Because the second part of my thoughts on this, Ricky, and when we talk about health disparities, there is a real disparity in who gets this level of care and attentiveness that is not necessarily tied to race. It is tied to money. It's tied to insurance. It's tied to class. It's tied to, yes, to race in a sense that, you know, some of the more affluent health centers may have these, but, you know, it's something that we really need to look at in terms of the disparity, because the patients who need it the most, who have the greatest psychosocial stressors and the least amount of resources, are the people who cannot necessarily gain access to these types of teams and utilize the resources. What good is Reiki if you can't afford it, if you have no one to watch your children, if if you're taking care of your elders, if you've got 10 million other things, or 2 buses and 2 trains to get there, right?
Yeah, and you hit on a good point. I think a couple of things. And Allison was very blessed because she went to Yale Medical Center. She had great insurance. Her husband works at Yale, and so she did have that whole package. I actually forgot about that. So I guess probably 6 weeks before she died, she was at doing chemo, and probably her second to last chemo. And the nurse came in and said, Allison, I want you to talk to the doctor. So the doctor comes in and said, Allison, you really need to get your plan in order. I think we should stop chemo and we are done. And so I was on Zoom with them, FaceTime with her. We were furious. How dare that stupid ass doctor tell her she's
right. They're giving up.
Went up who is he? He's not God. Like, what's his story? I'm furious. We're both furious. And so the next day she goes back, and so she explains to the nurse, I want another doctor. We hate that doctor. Get us a new doctor. He's an idiot. And so the nurse said, Allison, and she went back and basically reiterated, I want you to think about Simon and how you want to spend time with him. And literally 6 weeks later, she died. So they were right. But we were like fighting. But she did have a great resource and a great pain doctor, but also the chaplain of the hospital. She got very close to. And when you talked about that anxiety thing, because the pain that gives you anxiety is my cancer getting worse? Am I getting sicker? What's going on with my body? and that becomes the loop. Then the anxiety makes her have more pain, makes her
Mhm.
upset. Like, it's like, you're right about that cycle of anxiety
And
and
it's not stage dependent either. I have
No.
patients with stage 0 breast cancer who
that
are in
anxiety.
such severe, they're bound up and wadded up in such anxiety that every headache is metastatic disease.
Yeah.
Right.
You know?
Yeah.
Mhm.
Well, I did that. The first time I felt the bone pain from Neupogen, and like when you get when the
Oh, yeah.
at 4 o'clock in the morning, I'm on the phone calling my doctor, like, my cancer's in my bones, my cancer's in my bones. And of course, the doctor didn't answer. I went into one of my little support groups on the TNBC Foundation, and they said, Ricky, take a Tylenol, go to bed. It's the bone pain, and they should be, but that anxiety is just so high when any little thing you
Yeah.
feel, you think it's the cancer getting worse. So,
Yeah.
but my point was that Allison had a really, really great support system in her pastor and all the other stuff. She went to yoga, she did the Reiki, she did all that stuff.
Mm.
But still, you have to get to a point where you can't do it anymore.
Yeah.
She actually just became too tired
Right.
to do it, right? And but I think it's so important to have a good support system, and so
Mhm.
many of our Black patients are not getting it. And the data about the pain, even the pain relievers to Black women, they're not taken seriously, they're underdosed.
Yeah. Oh,
And
you're drug seeking. My favorite,
Mhm.
you're drug seeking. Oh, I can't tell you how many times in this clinic, um, oh, I'm in pain. Oh, well, she's a little squirrely. We don't really want to prescribe any more pain medication. We'll send you to Kimberly.
Or
Right.
she's histrionic. Yeah.
Yeah, and so I'm examining and I'm like, and I get a scan and I'm the one explaining that it's come back. Or I'm the one that's sort of saying, well, that no, this is normal. And if you get told, we see this a lot. We have a fair amount of sickle cell patients, and I've taken care of a few in my life. And I have a partner here that does it named Jesse Sudalter, who's amazing, who has done this for a really long time. And, she always comments on how fearful it is to talk about pain because you're afraid they won't take care of you. And I recognize this I recognize this point when I send a patient to the emergency department and they're in pain. I call the ER doctor and I start begging. I start begging. I'm like, and they are this wonderful person, and they have kids, and he has a job. And I'm thinking, and one day it occurred to me, did I just tell the ER doctor that this person has a job and 3 kids, and that he's graduated? I did everything but pull out his high school transcript. And what I realized is I've been socialized because I'm so fearful that they're going to go there and nobody's going to treat his pain. That they're going to
Mhm,
take one look at him and already decide what the story is, or bargaining or trying to figure out ways to avoid, the acute care centers. Can we just do a direct admission? Well, no, it's crazy because they have, mental status changes. Patients begging me. They had PTSD
Mm.
because of how they've been treated. Is specifically around pain. So on one hand, we tell people, no, why didn't you tell us you had, this is what they do to me, and my favorite, why didn't you tell us you had pain? Why didn't you tell us you had pain? We would have taken care of you. And I'm thinking, no, you wouldn't have.
Right.
No,
Right.
you wouldn't have, because they would have told you, like, this is not imaginary. There are too many people, especially people of color and people who don't have any money, particularly where I live,
Yep.
where the moment they show up and people look them up and down, size up what they're wearing, listen to the twang in their voice, and all of a sudden decide that they can wait in the ER.
Mm.
So I
Yeah.
was like, I was like, I was so appreciative after George Floyd died when everybody took a knee.
yeah,
Yeah.
But I'm like, you all could stand up if you would just treat my patient fairly.
yeah,
And it's tough because narcotics are vilified, right?
Mhm.
But alternative, complementary and alternative therapies are as well.
Yeah.
And so where is a patient to fall if you cannot use every tool in your toolbox that you know of, right? That
Mhm.
you have at your fingertips to treat my pain, but then you shun some of the other methods, or you discourage some of the other methods that I might use. Where does that leave a patient, and how, how better then should we learn to integrate these therapies? And I wish that more doctors could see this conversation, because it's so important,
We have to relinquish our fear at some point.
Mhm.
You know, at some point, how we have internalized, I think, the opioid crisis, and our mistakes around the prescribing, which we just this was an epic fail on the healthcare system. So what we've done, that instead of, we've become frightened, we've become scared, and we push that back on the patient.
Sure.
Right.
Well, and we face that blame, your dental pain, your whatever pain, your surgical pain, and
Mhm.
then patients then would also, I think, we don't know how to address all the other aspects of pain that makes people take pain medication,
Yeah,
right?
no social support, no other place to
Nothing.
go.
Right.
So you don't get trained on how to manage pain in medical school.
Yep.
You are measured constantly with how much are you prescribing. It's criminalized in society.
Mhm.
And so now when you're faced with a patient, you're not entirely sure
You
what to do.
undertreat. It's
You
true.
undertreat, and especially
Right.
if the patient is a patient of color, a minority, or has lower socioeconomic status, which then, every implicit bias kind of thing sort of that sits inside of our brains, which have socialized to say, these people don't feel this pain the same way, drugs are a problem, I'm not going to contribute to the problem, I'm not going to get played, overrides our medical training. So we have to think about it in a different way. And then you have the patient who's like, I'm not taking that.
Mm.
I'm not going to live that life. They're
Mhm, mhm.
terrified.
It's
Yeah,
true.
right, which was Allison, I don't want to get addicted, but then also,
They're
so
terrified.
think about that 1 to 10 thing. So as a doctor, even, so my pain's a 5. So how much meds are you gonna give me meds for 5, or do I have to be a 10? So as a patient, do you lie and say you're a 10 to get the meds that you need? Do you know what I mean? It's like
Wow.
this whole conversation about,
Yeah.
it's almost a negotiation about, well,
It is.
how bad is the pain really, right?
Yeah.
What do I believe as a doctor? How do I describe it as a patient? And what do I need to satiate this pain? Like, how do you even make that formula work, right?
Mhm.
I'm telling you I hurt really bad, then how do you know I hurt really bad? How do you know I hurt worth morphine? Do I hurt worth Percocet? Like, how do you know it? How do you sort of judge that level of pain to say, okay, Rick, you're out of control? Like when I had my mastectomy, I woke up from that surgery and I felt like, I remember sitting up in the bed when I came to, like, oh my God, I felt like a truck drove through my chest, backed up,
Mm.
back through my chest and drove through it again. I had never had pain like that. I had never felt
Right.
pain like that. And I remember like, oh my, like, whoa, like, what is this? And then, so, they dosed me up with Percocet, and then I was like a Zulu head, and I didn't like the feeling of it. I didn't want any part of it. I went for 3 days on Percocet, and then I went cold turkey. I'm not taking this stuff anymore. I can't think straight, because I felt so uncomfortable not being able to be lucid. And then the pain came again. And I remember sitting on my sister's lap, crying like a baby, because I had gone without pain meds for 3 hours, and she's like, "We just take the drugs, or you can't live like this." But that pain was nothing compared to what I saw Allison go through. So how do you know? How do you have this negotiation about what hurts? How it hurts?
Because it's a conversation. It's talking about it. It's really talking about it and examining and being able to say, we're going to try this plan. And if this plan's not going to be successful, then this is where we'll go next. And the idea when a patient talks about pain, when a person talks about pain, that doesn't necessarily mean that that's going to equal a prescription, right? Or that doesn't necessarily mean that it's going to equal Percocet.
Right.
So you can present with pain, and if we're doing our jobs correctly, then the goal is to try to develop a treatment plan that's going to be right for you. So if a person comes in and says, look, Kim, I'm hurting really badly. I took some Percocet. It made me think I was Batman. Then I'm going to think about that. Think about what's going on with that person, figure out what else we can use, and tailor a plan and try. We'll negotiate and say, hey, I know that you think you need this dose, and I think we should try this dose first and let me tell you why. So we have to start treating people like they're smart and intelligent.
Mhm.
I don't need to walk into the room afraid that I have to say, hey, I don't think this is a good idea. I need to walk into the room and say, you, as the person I respect sitting in the chair, I know this is what you're asking for. Let me talk to you about what the downsides of that are. Let me explain why I think we should start here. And if this is not working, not in 2 weeks, because you know right away it either works or it doesn't for
Right.
many of these. And one, depending on the medicine, usually in the first day or at least in the third or fourth day, we know we're not going in the right direction, then we need to change course. So what your patients are looking for is somebody who's going to partner with them in this. And so their responsibility is to report, and our responsibility is to engage you to work together to try to find a plan. And then our other response, and when people are worried about addiction, because we used to say you couldn't get addicted to opioids if you had cancer. Well, that's not true.
Not
Of course you
true.
can. But so what we should do is have the discussion that, yeah, that could be possible, but that doesn't happen to everybody, not even the majority of people. And if I see you going off the rails, I will tell you. I will tell you. And I will,
Yeah.
and it will, but you need to have that upfront kind of honest relationship with the person that you're working with. So I think, Dr. Gray, you're absolutely right. Dr. Gary, you're absolutely right. Having palliative care integrated early, but sort of thinking about it, not because palliative care can kind of be a loaded term for people to accept and for their families to accept, but you need the doctor that's going to be taking care of the you.
Mhm.
And
Mhm.
you have other stuff going on. Here's your cancer, and we need the cancer specialist, and they are the bomb, but their job is to fix the cancer. And when they consult me, my job is to help you be the best you can be, so you can go and do this, incredible journey or clinical trial.
I love that.
And yeah,
And I wish that more of us would see it that way, that we would brand it that way, that we would explain it to patients that way as well. And I think that there's a real opportunity to do so and to reintroduce these concepts early, because you are an essential part of the care team, the continuum of care, not end of life care. It's not just an end of life issue. And I think that's the message. If people get nothing else from this, is that it is not just an end of life issue, but it's a quality of life issue.
And you quality of life, whatever stage. So you guys, let's talk about marijuana. So
okay.
I'm gonna go back to Allison
Let's talk about it.
my kids, made marijuana butter. I had no idea what I was eating. And then one day I woke up like, you guys, what is going on around here? Like I had no clue.
Don't start with eating.
I know. So I wasn't eating. I lost 30 pounds. My kids just gave it to me. I didn't know what I was eating. I had no taste buds anyway. But anyway, Allison was really resistant to marijuana because she thought it was going to mess with the drugs. And so she didn't have really good information about that because her doctor didn't talk to her about it. So what is the deal? Like, what should people do? How can they ask for it? And, now it's legal. A lot of places, you don't have to even wait for the doctor to give it to you. But what's the deal?
It's complicated. So
To say the least.
it's complicated. So basically what we did was we ignored it. A whole bunch of people started using it. Then we said it was okay. We should use it medically. But I missed the marijuana class, the pharmacologic class in school. So I love how they say, go talk to your doctor when your doctor can't even spell it. They're like, how many?
Right.
Mhm.
I hear you. I didn't know anything about it.
So what I explained to people, depending on where you are, and this leaves this space is sort of ripe for, how do I want to say it? That marijuana and management of symptoms and marijuana and what people are hoping that it can do for cancer lives in the area of almost like faith and religion
Mhm.
and belief. I
Okay.
believe it. So
Okay.
when you are walking into and you start to question that or attack that, people have very visceral and very kind of emotional reactions to it. So what in our clinic, we do place people on the cannabis oil registry and we do a lot of education. And part of what I want to do is sort of take the idea of marijuana out of the ethereal and bring it down to a medication and a tool, and a medication and a tool that we don't understand very well. So I explained that my hope is that this will help you feel better. Any other benefit you receive from it is a blessing, and we
Mhm.
don't fully understand why,
Mhm.
but we don't discount it because
Mhm.
discounting it never helps.
Yeah.
But I don't want to couple that belief that marijuana treats or cures cancer, because we don't have that. We
Okay.
don't have the evidence to say that. And there are a lot of people buying a whole lot of stuff and getting taken advantage of. So if you can trust us that the data that we're having is letting us know that it may be helping with some symptoms, and it may not help with everybody. I mean, I have people telling me I failed marijuana. I'm like, you didn't fail marijuana, it just didn't work for you. So we're going to try something else. It's just not that.
Marijuana failed
There's
you.
there's still psychedelics. Don't worry about that. There's some
Sure.
mushrooms in the back. We can try those.
Uh-oh, there you
But
go.
but sort of thinking about the idea that the data behind whether or not it helps with appetite, whether or not it helps with
Yeah.
pain,
Help me with that.
because it's
Mhm.
been because of the way it's been scheduled in our country, we don't have the data and the trials to be helpful. And because we don't have a source that's produced with fidelity, then it's very hard to reproduce.
Right.
So what I usually explain, Georgia's may decriminalize low THC oil, the kind of oil you give to babies with seizures, which does have some clinical evidence behind it. I explain that if it is helpful, then we can use it. We help dose according to the side effects. This is what I think it might do.
Okay.
It's either going to help great, partially help, or it's not going to help. And that's okay. If it doesn't, we'll move on to the next thing. But this particular preparation won't harm.
Mhm.
The higher the THC, or the part that's recreational, that's when you get more side effects, the sleepiness, the confusion, the things that cancer patients don't particularly like. You're already tired. Now I gave you something that made you more tired.
Right.
The idea to understand and know the difference between the strains. Some strains are activating, some
Mhm.
strains are more sedating. And you have to kind of understand that I have patients who say, I took that, it was terrible. I didn't sleep for 3 days. I'm like, what did you take? Like,
Hey.
nothing with an S is not for you. Sativa is not for you. That's stimulating. Indica is in the couch. And they're like, oh yeah, they'll actually go and say, I
I
want
never
what's,
did that. That's
I
In
know
the
that
cut, right,
you have a
in the
bunch of
cut.
people running around going, asking for that. But
yeah, I love it.
so your best bet, if you are in a state that is legal and has dispensaries, unless you're going to a physician that has done extra study, you are much better off sometimes actually going to the dispensaries and telling them what your symptoms are. And then they will probably direct you, at least bud tenders or the pharmacists there direct you in what
Mhm.
theoretically might be better for that, or what they've seen other people respond to. And that's as kind of as good as you can get.
Mhm.
When you're older, more side effects, increased risk of falls, and
Yeah.
Yeah,
so
slower clearance, right.
right. So whatever they tell you to start with, okay, start with half, half of that. But it does require that you sometimes look outside of the people with the white coats. When your allopathic doctors just say absolutely not, or they say they won't talk about it, what they're telling you is that we don't have the education, and
Mhm.
marijuana doesn't rise to the level of a randomized clinical control trial. Like your lisinopril, nobody is, you take it out of the package, it's been studied. With marijuana, I mean, you don't know who grew it, you don't know
Right.
where it came
And
from, all the different
That's
strains.
true.
So it's incredibly complicated. And this is because of how we approached it in this country in this crazy way.
Can you trust dispensaries? If it comes from a dispensary, can you trust that?
You are relying on kindness of strangers. Many
Hmm.
dispensaries do have internal quality controls. There's some who are really trying to do the right thing, but there's nobody sort of watching the house. This is all self-regulated. So even your vitamins. So if you go to like Kroger, you get some turmeric and it says 1,000. the only thing that's required, one capsule of turmeric might have 500, one might have 1,500 milligrams of turmeric, but on average it's 1,000. So, you know, sort of thinking about it like that. So incorporating marijuana, but doing it in a realistic way, knowing that you are sort of relying, paying attention to your symptoms, but not placing all your faith in it, is incredibly important. And being open with your physicians, because it does interact with some medications like
Yeah.
your Coumadin, your oral hypoglycemics. You have to think about some of your chemotherapies. There was a recent trial looking at it with immunotherapy and questioning whether or not it changes the effectiveness. It didn't change survival, but so we're just scratching the surface of what this can do. So I think cancer organizations banding together to demand more research, like NIH level research into understanding.
Mhm.
You say it could
Mhm,
possibly,
mhm.
but we need to take these trials to the next level. If we're going to use it, we need to be studying it better.
And by and large, there are institutional trials. I know that
Mhm.
here in Pennsylvania, there are a number of trials looking at the benefit of THC and CBD for things like neuropathy,
Absolutely.
for side effects, for symptoms, but for the therapeutic benefit of treating cancer, there is no data. And I think that's an important thing to mention to people
Yeah.
watching, because it is very much like the next CMOS or cauliflower or whatever else that people
Well,
think
remember
is sort of
Laetrile?
a panacea. Yes, I do. And it is not a panacea for treating cancer, but it certainly can help. I have a number of patients who utilize CBD drops for sleep, for chronic pain, for anxiety, and the concentrations again are variable. There are some organizations that do help to do some quality control for non-FDA approved substances, but you should really check the labels and look into it very carefully, because every strain is different, every concentration is different, and every person's reaction to it is different. And so with that many variabilities, how do you even begin to tease out the standard dose, the side effects, and all of the things that people really want to know? But the reality is that there can be benefit, and there are physicians who are studying it more and more, who are trained in prescribing it. And for people who are watching, if your doctor shuns it completely, it's because they don't know anything about it.
Yeah,
It's a sign of
absolutely.
their ignorance. Yeah.
Absolutely.
I remember getting high in college and thinking, I don't know if I can do this for my.
Yeah, the idea of like CBD and the use of hemp, and knowing the difference between hemp and traditional marijuana, and CBD for anxiety, which is not psychoactive. We have quite a few patients that use. I think being careful about where you're buying it from. Anything that involves a van is not a good idea.
Like those-
No. If it involves a van, or not a good idea. I think the other thing there's very popular is something called Delta 8, where they have been leaching all the THC out of hemp. Don't use that.
Yeah.
Don't do that. That's not helpful.
Maybe marijuana's another episode.
Yes, that's another whole
Definitely.
other show. We should have a whole
Definitely.
other show on marijuana. But yeah, I
Agree.
just like to get out there. Like if it has an 8 behind it, just no. Kids, don't give mom that.
I know my kids have given some gummies to my parents. Very funny. Wow. Thank you. Thank you.
Thank you.
So much to talk about. We'll do another show on marijuana.
Yeah. And still so much more, exactly, as we talk about the different types of pain. I'd love to see the episode where we look at some of the side effects of things like aromatase inhibitors and bone pain and other things, and start to help patients symptom by symptom with some ideas of how to stepwise treat and deal with, and have the conversation with their doctor about those things. So that is definitely a show that's coming up, where we're going to actually tackle people's specific types of pain and maybe just give some approaches. And it's going to be general because everybody's different, but we can help to start to give you some questions to ask your doctor and some ways to think about your pain. And so that's going to be a great conversation, and we'd love to have you back for it.
Yeah. we
Oh
love-
yeah, I love, not that I love AI pain, but and number one, AI pain's real.
It is, it's real.
It's
Thank
not
you.
it's not a minor side effect. It causes you how to get out of the chair. You have to rock to get out. Yeah,
Yep,
that's,
Yep. If
yeah,
any of my patients are watching, you know that I tell you it is real, it's true, it's not in your head, it's not a figment of your imagination at all. Estrogen blockers are not, they're not fun. They are necessary when they're necessary, but there are very real side effects. That's true.
Mhm.
Wow. All right. So we'll schedule that episode with you soon. And
It is.
gosh, you guys be blessed. Thank you, Dr. Kimberly.
Thank
Mhm.
you.
So good to see you, Doc. Oh my
Good to see you.
goodness.
I know.
Listen, we hope this has been relatable and reliable and real. It's what we set out to do every single Wednesday night.
Mhm.
We have our anniversary coming up. Ricky, you want to talk a little bit
Yeah,
about
we
it?
have our anniversary party, the Magic Touch celebration. Thank you for your magic touch to everybody who supported us and loved on us and given us money and given us, information, and all of our people on our shows. We're going to dance on Sunday if you're in the DC area, 3:00 at the Hill Center in DC. Please be have done your COVID vaccine, but come dance with us. We have a hot DJ, we've got a magician, we've got food trucks, and I got my tutu.
Yep.
I got like 4 tutus. So
I hope you have one for me because I don't have a
Of course.
single tutu. I've never worn a
Okay.
tutu in my life. I got 2 left
Okay.
feet, so.
I got you. I got you too, when I can help you dance, but we are going to be
Love it.
rocking it. If you want to buy tickets, email me at ricky@touchbbc.org or go to Eventbrite and put in Magic Touch and you'll find our tickets, and we are going to have a blast. We're going to have a
Yeah.
blast. So thank you, everything. I love you guys. Thank you, Dr.
Love you too.
I'll see you soon. Well, I can't believe you're coming to my house.
I'm so excited. Good to see you, Dr. Kimberly. I can't wait to see you again. I can't wait to
Yeah.
meet you in person.
Good to
Take
see
good
you.
care, everybody, and we will see you next Wednesday night.
The doctor is in.
Dr.
Rest
Zinn,
love. Rest love.
Christy Love.
Rest love. Bye.